Hi friends, welcome to classes by Lab Doctor. In today's class, let us discuss about hypophosphatemia. So, you all know that phosphorus is an important mineral mostly distributed in the bones and some of it in the soft tissues. So 85% of this phosphorus is bound to calcium and it is seen in the bones, and 15% of it is intracellular. So this phosphorus has an important role. It is needed for the bone and your teeth function, for maintaining your energy levels like for ATP generation. It is required for a genetic material for the formation of adenine, guanine, etc. in our DNAs and RNAs, helps it to form the cell membrane, the phospholipids, maintains the brain and the nerve health, maintains the acid base balance, and helps in the delivery of oxygen. So normal level of phosphorus would be anything between 2.5 to 4.5 milligram for adults. When the level of phosphorus goes below 2.5 milligram per deciliter, we call it as hypophosphatemia. What are the causes of this hypophosphatemia? So first cause would be a refeeding syndrome. So what is this refeeding syndrome? Refeeding syndrome is the metabolic disturbances that occur as a result of giving nutrition to the patients who are severely starved or malnourished. So once you start them the feed, when you refeed them, within 4 to 5 days, what happens? There is shift from the fat to carbohydrate metabolism, and then there is sudden rise of insulin because they are starving, they are malnourished. The fat is the one which is used to give them the energy. So now suddenly when you start feeding them, what happens? The metabolism shifts from fat metabolism to carbohydrate metabolism. Whenever there is carbohydrate metabolism, insulin has to come to play, so the insulin level will rise. When the insulin rises, what it will do? It will pull all the phosphorus, proteins, glucose inside the cell. So the level of phosphorus decreases in the serum. It causes hypophosphatemia. So this is a normal cell. The insulin, what it will do? It will push the glucose, phosphates, thiamine inside. So then the level of phosphate outside will reduce. So there is hypophosphatemia. So alkalosis can also cause hypophosphatemia. Alcohol abuse, it can also reduce the calcium, it can reduce the phosphorus also. Malabsorption, like suppose if there is any GI damage, or like either because of a sprue or because of an ulcerative colitis, Crohn's disease, inflammatory bowel disease, all these can cause decreased absorption of phosphorus, and that can lead to decreased phosphorus levels in the serum. Suppose if there is vitamin D deficiency, or there is a chronic use of phosphate binders like sucralfate, etc., or the aluminium containing antacids, they can also reduce this phosphate level. Sometimes patients keep taking antacids for a long time, especially such aluminium containing antacids and all, they can reduce the phosphate level. The other causes of low phosphate would be hyperparathyroidism. So I've told you, whenever there is increased parathormone, it will increase the calcium level. It will increase the resorption of the bone. It will increase the absorption of calcium from the gut. It will reduce the excretion of calcium from the kidney. All this, what it will do? It will increase the calcium and reduces the phosphate. So basically it will do this by increasing the excretion of phosphates in the kidney, and hence there is low phosphate level in the blood. Whenever there is congenital defects of tubular phosphate reabsorption, so you know that kidney plays an important role in reabsorbing these phosphates. So if there is any defects in the absorption itself, so the most of the phosphates will be lost, and then there would be deficiency of the phosphates. If there are non-absorbable antacids like aluminium bound antacids like aluminium hydroxide, etc., this will prevent the phosphate absorption and can reduce the phosphate level. If the patient is having diabetes and there is a treatment given for diabetic ketoacidosis like insulin will push the phosphates inside the cell and reduce the level in the serum. Severe dietary deficiency or oncogenic hypophosphatemia. So I have told you. So now what are the signs and symptoms of this hypophosphatemia? So I've told you that this phosphate is a very important mineral. So what happens is whenever there is low phosphate, your cellular ATP production, everything is going to reduce. Your oxygen delivering capacity is going to reduce. So apart from the mineralization work, these things are affected, and these are the ones which will lead to the symptoms of this hypophosphatemia. So I have told you, whenever there is low phosphate, that is your red cell 2,3-DPG diphosphoglycerate level falls, and the affinity of hemoglobin for oxygen reduces, and the oxygen release at the tissue level is affected. So once the oxygen supply to the tissue is affected, definitely there is going to be weakness, there is going to be respiratory depression, all these things are going to happen. And the intracellular ATP, adenosine triphosphate level falls because of the low phosphate level. This can also cause the decreased in the energy dependent functions, and the patient will have symptoms. So the patient can have muscle weakness, muscle dysfunction, respiratory dysfunction, low cardiac output, respiratory muscle weakness, sometimes respiratory failure also. So how do we treat this hypophosphatemia then? So the treatment depends upon treating the cause, so that we rectify the cause, what is causing this hypophosphatemia. Along with that, we will have to manage the patients of this hypophosphatemia, dividing them into whether it is a very severe hypophosphatemia or it is a mild hypophosphatemia. Suppose if it is a mild hypophosphatemia, then we can just give them oral replacement therapy of this phosphates, like around 1000 milligram per day. Suppose if it is moderate hypophosphatemia, then and if the patient is on ventilator, then we will have to give them the intravenous phosphate therapy. And suppose if it is severe hypophosphatemia, when the level of phosphate is less than 0.3 millimoles per liter and patient is critically ill, we will have to give IV replacement therapy over 2 to 6 hours. Along with that, we will also have to correct the other disturbances of calcium, magnesium, etc. for maintaining the homeostasis. So hypophosphatemia sometimes can be life-threatening because it will interfere with the cellular functioning, with the cellular level, may it be the ATP generation or may it be the supply of oxygen through 2,3-DPG. So that is all about hypophosphatemia. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.